Hello, my name is Fernanda Biancolini. I'm a pediatric and fetal cardiologist. I work at a pediatric hospital in Buenos Aires, Argentina, and thank you for the invitation. I have no conflict of interest. As we look across South America, what we see is a story of fragmentation. Registries do exist, but they are not equally strong or equally accessible. Some countries have made remarkable progress building national database and surveillance systems. Others still rely on local or even hospital level efforts. This means that a child's chance of being diagnosed with a congenital heart disease before birth can depend entirely on where that child happens to be born. This inequality in data, access, and outcomes is something that we must acknowledge if we truly want to improve prenatal detection and care of every child across the region. What we can observe here is that only a handful of South American countries have structured functional national registries for congenital anomalies, and even fewer consistently collect prenatal data. Pulse oximetry screening represents a great opportunity for early postnatal detection of critical congenital heart diseases, and Uruguay stands out as a regional success story. It implemented mandatory national screening back in 2018, setting a strong example for policy based action. When we compare universal health coverage, the correlation with diagnostic access is evident. It is not just an index, it's a mirror of equality. Countries as Chile and Uruguay, both with indexes around 80, lead the region in surveillance and detection systems. In contrast, Paraguay and Bolivia, with indexes below 65, still face major gaps in access and early diagnosis. Variations among registries driven by difference in methodology, completeness, and underreporting. This highlights an urgent need for standardized, coordinated surveillance across the continent. Chile offers a strong model. National guidelines recommend field cardiac screening between the 20th and 24th week of pregnancy. Postnatal oximetry screening continues to expand, and integration between obstetrics and neonatal programs is steadily improving. Argentina is also moving forward. In 2023, the cardio law was approved, recognizing the ongoing need for prenatal detection, treatment access, and comprehensive protection for patients with congenital heart disease. Through the RENAC system, the country now tracks prenatal detection by anomaly, with notable improvement in data completeness. Yet, universal prenatal screening remains a goal to be achieved. Together, Chile and Argentina demonstrate that structured registry, clear guidelines, and national policies framework can significantly strengthen early detection. These models can and should serve as a framework for other nations across South America. When analyzing prenatal detection rates across South America, one of the main challenges we face is data inconsistency. Several countries still lack recent published national figures, and much of the available evidence comes from subnational registries or hospital based series. Reported prenatal detection rates vary depending on several factors. First, whether the data includes all congenital heart diseases or only critical lesions. Second, the availability of fetal echocardiography and trained professionals. And third, whether the figures come from population based registries or tertiary referral centers, which tend to show higher detection rates. Countries with robust national registries, such as Argentina with RENAC, are able to generate more representative and comparable estimates. Now, focusing on Argentina, The national registries provide one of the most complete database in the region. Between 2013 and 18, the prenatal detection rate for critical congenital heart disease was 43.9%, with an estimated prevalence of 11.46 per 10,000 births. However, significant disparities were observed across jurisdictions. For example, detection ranged from around 40 in Buenos Aires province to over 60 in Cordoba or Buenos Aires city. If we analyze health subsectors, the inequality becomes even more striking. Prenatal detection reached 64.9 in the private and social insurance sector, but only 39.8% in the public sector. This gap clearly reflects inequity in access to specialized fetal echocardiography and diagnostic resources. It's also important to emphasize that the analyzed period 2013 to 2018 represents a snapshot in time. In recent years, detection rates have improved thanks to expanded training and introduction of structured screening protocols. The takeaway, the key here is that robust, standardized national surveillance systems are essential. They allow for reliable comparison, continuous improvement, and ultimately better outcomes for newborns with congenital heart diseases. When we look more closely, the crack becomes clear in skills, in system, and in policy alignment. Across many regions, access to prenatal echocardiography remains limited, particularly outside major urban centers. This means that many pregnancies never have the opportunity for a detailed cardiac evaluation, not because of lack of need, but because of lack of trained personnel or equipment. Referral systems are often fragmented with inconsistent communication between obstetrics and pediatric cardiology teams. As a result, even when a cardiac anomaly is suspected, follow up and confirmation can be delayed or lost entirely. In addition, there is still no uniform national policy for prenatal detection of congenital heart disease in most countries of the region. Screening largely depends on local initiatives or individual expertise rather than coordinated national programs. Finally, there's a pressing need for standardized congenital heart disease reporting. Without unified definitions and comparable data, it is difficult to measure progress and even harder to design effective interventions. These gaps represent loss of opportunities for early detection and for timely, long saving care. Reaching this requires not only technology, but training, coordination, and political will. Well, we already know that congenital heart diseases are one of the most frequent congenital malformation and the most frequent cause of mortality during the first year of life. Reported prenatal detection is still low and varies within the same country, even in developed countries. Argentina is large, with great inequity throughout the country. Access to medical care is extremely difficult in distant regions. Main cardiac centers are centralized in the capital of Buenos Aires. When there is a suspicion of congenital heart disease, there is a national program in charge of referring the pregnant woman to a cardiac center depending on the possible requirements of the future newborn. Our hospital is one of the children's center with cardiac surgery, and we have a prenatal multidisciplinary committee fully and constantly connected with the maternity where the baby is planned to be born. This allows a comprehensive assessment of the mother child binomial to plan the initial approach at the maternity and to coordinate efforts to safely transfer the newborn to our hospital. And of course, to accompany the family during this life lasting journey. This pathway works if there's suspicion of congenital heart disease, what brings us to training as a key point. Prenatal detection of congenital heart diseases enables planning and decision making. We should remember that most of them do not have hemodynamic repercussion in utero, being the safest way of referral to prevent transport of clinically ill patients and perform the surgery in the newborn in the best possible conditions. And this has proven to reduce morbidity and mortality among critical congenital heart diseases. So, should all pregnant women undergo fetal echocardiography? Well, in 2007, Ackerman proposed universal fetal echocardiogram given that standard fetal ultrasound failed to diagnose most congenital heart diseases. As reported in several studies, most of them are detected in low risk pregnancies. So, yes, fetal heart scan should be offered to every pregnant woman. But who should do the echo? There are not enough cardiologists trained in fetal echocardiography enrolled to scan every pregnant woman. And even if there were, each would have to scan for 300 hours to pick up on one serious congenital heart disease. Besides, pediatric cardiologists are not used to a screening situation where pathology is found occasionally. And finally, one extra scan would most probably not be cost effective and insurance would not finance it. So, who should scan the fetal heart? General or obstetrical sonographers trained in fetal heart screening. When should it be done? During the routine scan of other fetal anomalies during the second trimester. Many studies have shown that abnormalities during the obstetric scan is the indication for detailed fetal echocardiogram with the highest correlation with congenital heart disease and that they are mostly diagnosed in low risk pregnancies. Suboptimal imaging has increased the number of referrals and it's been proven to have the lowest yield for diagnosis of congenital heart disease. This overburdens pediatric cardiologists and training of obstetrical sonographers is one step towards decreasing unnecessary referrals, leaving high-risk pregnancies and suspicion of congenital malformations for the pediatric cardiologist. There are several guidelines on how to screen the fetal heart. We're not going to stop here. Many studies have demonstrated the impact of educational programs to train obstetrical sonographers in fetal heart scan to increase prenatal detection of congenital heart disease during the routine fetal scan. Effort has also been focused toward community educational programs for general or obstetrical first level ultrasonographers in order to decentralize fetal heart assessment and ensure equality of access to prenatal diagnosis in peripheral, non academic obstetric units. There's strong evidence that training and experience influence prenatal detection, and there is important improvement over time. Most groups agree that even with an increase in detection of outflow tract pathologies, it's still low, and that an educational effort should be focused toward these anomalies. Still, second trimester screening has certain limitations to detect valvular anomalies, probably due to progression of these pathologies and the lack of use of color Doppler. It's been posed that improving prenatal detection rates through improved ultrasonographers training could result in considerable cost saving. Studies endorse institutional, national, and international standardized protocols and educational programs as one of the main steps towards increasing prenatal detection. The establishment of a scan registry is strongly recommended to ensure high quality of screening and also appropriate auditing of outcomes. Are the same barriers we hear about in every conference: resource, training, and data. Limited training in fetal cardiology remains one of the most fundamental challenges. In many regions, obstetricians and sonographers receive little or no exposure to advanced cardiac imaging during their initial training, and continuing education opportunities are scarce. The second barrier is the available equipment in the public sector that is outdated, which directly affects image quality and therefore diagnostic accuracy. Third are socioeconomic disparities. Access to specialized care and even to a basic screening ultrasound often depends on the family's geographic location or income level. And finally, data and reporting continues to limit our understanding of the true burden of diseases. Without reliable, comprehensive data, we can't measure improvement or identify where interventions are most needed. These barriers are not new, but they remain deeply persistent. Addressing them requires substantial investment, standardized training, and commitment to cardiac care, equitably and data driven. A group interested in the barriers for fetal heart scan designed a survey to investigate ultrasonographers' perspective. The lack of knowledge of the fetal heart and cardiac screening were the key barriers associated with self-reported ability to perform the heart scan. An important finding was that for non-tertiary sonographers, the belief or the lack thereof in the usefulness of imaging influences their intention to perform the outflow track view. Other key conditioning factors reported were self-confidence, supervision or colleagues' expectations, equipment, time to perform the echo, patient habitus, and the need for feedback and reinforcements from supervisors and colleagues. In 2019, we performed our own survey to identify the barriers affecting our own population of ultrasonographers. 79% of the responders had training on the assessment of fetal heart during their basic education. Even so, almost 55% of these identified a lack of training and lack of self-confidence as an important barrier during fetal heart scan. The barrier mostly voted was the lack of time and or adequate technology, followed by lack of training and self-confidence. Regarding self-confidence, 48% of the responders chose working in a multidisciplinary environment with help and feedback from specialists as a key factor to improve self-confidence, followed by better training. Over 90% attended additional training, but 40% find it insufficient. Regarding training, 56% chose lack of finance and more than 46% lack of time as an important issue to attend additional training. Finally, we ask about methods to improve training, and 56% chose monthly supervised hand-on spaces as a key method to improve educational training. The recent approved cardio law represents a major step forward in protection of individuals with congenital heart disease. This law focuses on three essential pillars: early detection, access to treatment, and integral protection. It acknowledged that detecting congenital heart diseases early in pregnancy is not just a medical achievement. It's an opportunity to plan delivery in a center equipped to provide the right care at the right time. A key component of the law is ensuring the training of all obstetrical sonographers across the country, beginning during their basic ultrasound education and guaranteeing continuous access to up-to-date professional training. This law builds a comprehensive framework that connects early detection with long-term outcomes, ensuring that every child, regardless of where they are born, has the chance to receive adequate treatment and long life care. As we reach the conclusions, it's clear that opportunities ahead are as important as the challenges we have discussed. We must continue to strengthen national registries, ensuring that data are complete, comparable, and transparent, because data are the foundation of action. We need to expand training opportunities not only through traditional method, but also by leveraging teleechocardiography and remote mentoring, bringing expertise to where it's most needed. Regional collaborations are key. Shared protocols, multi-center registries, and regional training networks can help us bridge the inequities that still persist across South America. We should also integrate prenatal and neonatal screening programs, creating a true continuum of care that begins before birth and continues into postnatal life. Ultimately, prenatal screening must be seen as a path towards equity and a tool that ensures every child, regardless of geography or socioeconomic background, has the same chance at life and health. Those are not our goals, they are our shared responsibility. Thank you for your attention. Teaching and training should be multiplying, create networks,